think you can go ahead, Dr. El-Reyes.
Good morning, and thank you for joining us this morning for Winship Grand Rounds. If you are an Emory University or healthcare employee and would like to receive a CME credit hour for attending today, the login information can be found in the chat feature on the bottom of your screen. If you have any issues with the webinar or the CME login, please send Julie Hawkins an email or drop a note via the chat feature. This morning, we are excited to welcome Dr. Scott Kopetz. Dr. Kopetz is a professor and deputy chair of GI medical oncology at MD Anderson. He received his medical degree from Johns Hopkins School of Medicine and residency training at Duke University, followed by a PhD in cancer biology and medical oncology fellowship at the MD Anderson Cancer Center. Dr. Kopetz serves as the program leader for the GI program and the colorectal cancer moonshot at MD Anderson. He is the chair of the NCI Colon Cancer Task Force and is the vice chair for colon cancer in the NSABP, RTOG, GOG cooperative group. Dr. Kopetz has developed a translational and clinical trial program in colorectal cancer, which has resulted in FDA approval of BRAF EGFR inhibitor combinations for patients with BRAF V600E mutated colorectal cancer and PD-1 CTLA-4 inhibitor combinations for patients with MSI high colorectal cancer. He also is an innovator in the development and implementation of circulating DNA into clinical management of minimal residual disease. And jointly developed the consensus molecular subtypes and RNA-based methodology for colorectal cancer classification that is now being widely integrated into retrospective and clinical efforts. Welcome, Dr. Kopetz.
Okay, no, thank you, Dr. El-Reyes, and really appreciate the invitation today to present. And I wanted to share some of the work that's been ongoing in colorectal cancer, really looking at adaptive and acquired resistance. So I'll start with some disclosures. So a key point that I want to make sure that I communicate today is this concept of adaptive resistance. And this idea here is that homeostatic regulation is a really nearly universal feature of biological systems. And the idea is that perturbation of any given node in a complex network has adaptations that are built into this network, such as the network can reestablish its homeostasis. And this is especially true in growth pathways such as MAP kinase, where it's really critical that the biologic system gets these critical pathways correct. And so the idea here that inhibition of a single node can lead to this rapid compensation and signaling really is a concept that has been in the literature for several years. And this is a work from Gordon Mills, one of my prior colleagues at MD Anderson, now that's at Oregon, where he described this strategy for combination therapies where you're perturbing one node and then really looking to see how the pathway rewires and adapts to its signaling. And that this really then identifies a combination partner that can uncover this vulnerability that can occur. And so these combinatorial adaptive resistance therapies, as he described, really is the foundation of some of the work that I'll share today. So I'm going to share three examples, talk about some of the path of BRAF EGFR and BRAF V600E, talking about some of the older work, but then how these concepts are really being applied also in looking at G12C inhibitors and as well as CDK combinations with MAP kinase inhibitors. So I'll start with BRAF. So just acknowledging in colorectal cancer, BRAF V600E represents about 7% of colorectal cancer There are other BRAF mutations, 3 to 4% of patients. These are ones that have more complex signaling mechanisms. But what we'll be talking about when I talk about BRAF mutated is really the V600E mutation. I think we've long known that BRAF V600E is associated with really poor outcomes in colorectal cancer. So this is data looking across a number of different mutation subtypes in colorectal cancer, one of many publications. What you can see is a setting where we have 2.5 year survival now with metastatic disease, but in the presence of a BRAF mutation, at least prior to the development of novel inhibitors, the BRAF mutation is associated with less than 1 year survival. This also has very distant metastases patterns, has higher rates of peritoneal, distant lymph nodes, and CNS metastases. So the work initially began in this when I had the opportunity to study Vemurafenib in the initial phase 1/1b study, and we had cohorts of melanoma and colorectal cancer. And Vemurafenib was developed as a V600E specific BRAF inhibitor. And the shocking finding at the time was that we saw very different activity. So refractory melanoma had an 81% response rate in this cohort. And then the cohort of refractory colorectal, despite being the same study, the same mutation, same inhibitor and dosing, only had a 5% response rate. So really a kind of recognition that this was that there was some subtype and tissue dependency that really is driving this. Now, our first foray in trying to improve upon this was, again, following on melanoma, where the melanoma field was adding a MEK inhibitor to BRAF to improve outcomes. And so the thought was, well, if we're not really hitting the pathway sufficiently, let's double down on the BRAF and MEK. And to summarize another few years of investigation, we explored that and really disappointingly didn't see any differences there. You can notice that response rate perhaps is numerically higher. You get a little bit of deeper response than those that respond. But the inflection point, pointing where the arrows are here as one way to really interpret waterfall plots, really don't show any substantial difference with these agents. So this key preclinical finding that came up came out of René Bernard's lab was an unbiased screen using hairpins against a number of different targets in an HT29 cell line, and doing that in combination with Vemurafenib. And what this showed is that in EGFR really scored as one of the top signals in this unbiased screen, which was a little unexpected at the time, given that we had developing clinical data about the limited activity of EGFR inhibitor as a single agent in this population. But what is shown on the right is really this kind of feedback mechanism where a BRAF inhibitor results in EGFR activation, and that this can then be blunted by either monoclonal antibody or a tyrosine kinase inhibitor. So this work really led to this concept of signaling, where BRAF mutation constitutively active, signaling downstream the pathway. Now, the activated pathway is denoted here in green. But the idea was that by inhibiting BRAF, you can get a transient inhibition. But in colorectal cancer, there are fairly robust feedback mechanisms. Again, part of this adaptive network that's present in the gut epithelium and the colorectal cancer. And we get loss of these negative feedback mechanisms, many of these phosphatases. And as a result, you can then get increased signaling through EGFR. Again, EGFR was not a critical factor at baseline, but it was only when we uncovered this feedback vulnerability that EGFR became apparent. And this can then result in signaling down and around BRAF and restoring fairly rapidly, within a few hours, can restore the MAP kinase signaling. So the concept then of doing a dual inhibition of BRAF and EGFR then to inhibit that became area and direction to explore clinically. Now, this work, there's a number of different studies kind of looking at these various combinations, and I'll just share one of the early studies that we ran, and this is the VIC regimen, or Vemurafenib, Irinotecan, and Cetuximab, and this is a combination of a BRAF EGFR, but also with Irinotecan, and here's patients in third line and beyond. Now where we're able to get a numerically higher response rate and kind of shift the curve a little bit, even though Irinotecan alone is not particularly active in these patients. And our expectation for a patient with a BRAF mutation in second line and beyond is really a PFS of about 2 months with cytotoxic therapy, as I'll show. So we also liked Irinotecan because our preclinical models actually showed that you can induce an apoptotic, that you can get cell cycle arrest with MAP kinase inhibition, but the addition of the cytotoxic agent then induces a more profound apoptosis, and you can get better survivals, higher response rates in these preclinical models. And just showing one curve from one of our mouse experiments where you can see that the difference between the purple line and the brown line with extended survival. So this was the rationale behind the SWOG study that we ran of Cetuximab and Irinotecan versus the combination of Vemurafenib, Cetuximab, and Irinotecan with optional crossover there. The primary endpoint was met. Waterfall plots are as you see here, and you can see that really limited activity with the standard of care therapy at that point. The regimen had toxicity, some nausea, neutropenia, some anemia, diarrhea, and there were some arthralgias that led to occasional treatment discontinuation in patients as well. But the primary endpoint shown here was met, a hazard ratio of about 0.5, but really just reflecting the fact that the standard of care therapy just does so poorly with a median of 2 months. And so we're able to certainly increase that and have a much more profound disease control for a minority of patients, but really demonstrating that this is a population that still has substantial unmet need. So this led us to the question about how do we increase the response rate and the durability of the BRAF regimens. So for this, we returned back to the lab, now taking advantage of some of the patient-derived xenografts that we were able to establish. And what we've been doing over the years, and this is work with Chloe Atreya, was generating biopsies from patients going on to studies, establishing these patient-derived xenografts, and then treating them with the combination of a BRAF and a MEK inhibitor, and showing the regression in patients can be matched with regression with the combination in patients. So we took our 3 responders on the clinical trial and had PDX models, and what you can see is those 3 models that had some degree of response had a commensurate response in the PDX, while a model with progression likewise had progressive disease. So with this, we can then start to ask questions about the potential benefit of these various therapies. And here, looking at patient-derived xenografts and the potential of various combinations, here we can now start to deconvolve the various regimens and look at, in the mouse model, we can look at what components provided a benefit in a given patient. So here are patients that were derived from our VIC regimen, SWOG 1406, and others. And what we could see in these responding patients, now we could start to ask the question, well, what would have happened if what would we predict at least would have happened if the patient had just gotten irinotecan or just gotten the targeted therapy combination? And what we can see is that in these models, at least, the first one, you can see there was some benefit with as in the green line, from the Vem and Cetuximab, but it really took the combination to get a response that the irinotecan likewise added to it. And in the second one, you can see as well much more modest response with the Vem Cetux, but more interaction with the irinotecan, such that ultimately the model is regressing. But on the far right, you can see here's a patient, for example, that one would predict really didn't need the Vem Cetux. So this is one of the few patients that probably would have responded to the irinotecan alone, and really no evidence that there's benefit with the BRAF signaling, despite the fact that the patient responded to that regimen. So the other thing that we can do in these is to ask the question about, what are the potential things that we can do in some of these resistant models. And we can actually treat some of these models to the point of progression, and then ask the question about what sort of therapies could we do to administer, or to try to reverse the resistance. And so one of the components is these resistant models, and I'll come back to the mechanisms of how they develop resistance. But the resistant models, when we give very high dose MEK inhibition, these models can still regress. And one of the things that this tells us is that these models are still very sensitive to high dose MAP kinase inhibition, and that it's really, again, about the magnitude of pathway inhibition that we can accomplish in our patients. So fortunately, we had a number of biopsies that were done on these studies. And this is really kind of complex, difficult work to do. And I highlight the fact that we had a number of different patients enrolled on these various studies looking at combinations. And it's really a minority of them that have usable paired biopsies at the end of the day. This is just the reality of translational research, are the dropout of a number of samples. But what you can see is that as you start to go from doublets to triplets regimens, that you can start to see more evidence of MAP kinase inhibition. And this is in the setting of a triplet regimen in patients using phospho-ERK as a readout. But I think the really intriguing component of this is then when you actually compare this to what was seen with single agent BRAF inhibition in melanoma, we're still far from where we can get with single agent melanoma. So these are exact same assays that was performed across various tumor types, scored in an identical manner. What you can see is as we add different regimens in, different combinations, we can get a really profound inhibition, and but it's only with the melanoma that showing the BRAF inhibition as a single agent that we're still not where we need to be. So, how else can we learn from the patients and the models? Well, it mentioned that, we can treat these models to resistance and then ask, what are the mechanisms by which this is occurring? And here, again, we can take these models and treat for extended period of time and then profile the resistance models that appear. And here is an example that showed an acquisition of an NRAS mutation. Now, this is really interesting because, of course, classically, we know that BRAF and other and RAS mutations, KRAS or NRAS, are mutually exclusive in colorectal cancer, right? You just don't classically see a V600E activating mutation and and a RAS mutation. Now you can see atypical BRAFs, those will commonly, especially some of the class 3s, will commonly come along with RAS mutation. But here is a setting where the cells are acquiring a secondary mutation in the MAP kinase pathway. Now we can take that model and other models like it and replicate this process to really build out the landscape of potential mechanisms of resistance. And so we did this a number of times, and you can see some of the alterations that appeared in the mouse models: KRAS, NRAS, MEK1, EGFR mutations, for example. And this gives us a hint, because then we can go into patients and try to understand what those mechanisms are in patients. And we can actually use circulating tumor DNA. And indeed, we can identify KRAS, NRAS, MEK mutations. But we also had some atypical alterations that we weren't really sure what was going on. And so we had, a P10 mutation, a GNAS, an ARAF mutation that appeared in some patients. And we could actually, though, go and model these mutations in a model that looks at nuclear ERK2 localization as a readout of signaling and restoration of this signaling. And what one can see is that even alterations that one wouldn't classically think are MAP kinase activating, P10 mutation, for example, indeed what you can see is this does indeed have some binding and does indeed engage the MAP kinase signaling pathway. So at the end, when you look at all the different mechanisms of resistance that have been identified, what you can see are these RAS mutations, the pathway activation and inhibition, as well as a number of these other factors that all result in MAP kinase pathway reactivation. And we think about this as really a key signal about really reiterating the fact that it's not alternate pathways that are being engaged, but it's really how do we better improve that MAP kinase pathway. So this led to a continued push in the clinic to say how do we double down, look at triplet regimens to try to improve MAP kinase pathway. And so this is some work that Claudia Tria presented, initially looking at Dabrafenib, Panitumumab, Trametinib triplet. And here really, a sense that there may be a higher degree of activity. So all of this was kind of the background information that led to the design of the Beacon study. And we actually built this identically to the SWOG 1406 study. And looking at the control arm and second or third line of the FOLFIRI and Cetuximab or Irinotecan Cetuximab compared with the doublet of BRAF EGFR and the triplet of BRAF MEK EGFR. Now, at the time, we were absolutely convinced, based on the data that we had, that the best arm would be the triplet arm. And so the primary endpoints of the study were actually triplet versus control, overall survival and overall response rate, objective response rate were the primary endpoints. At the time, the regulatory agencies that had required that we use an EGFR inhibitor in the control arm. Again, remembering that the labeling for EGFR inhibitors are really excluding patients with a RAS mutation, but even now today still doesn't include BRAF. And so while we think that there's fairly modest activity of an EGFR inhibitor in combination with chemotherapy in these patients, that was the control arm for this study. So the safety lead-in showed very promising results at a fairly high response rate. We're certainly very encouraged. And the primary endpoint of overall survival, the triplet versus control, again showed a hazard ratio of 0.52. So in this study, we were able to meet the primary endpoint and substantially improve the overall survival. However, when we looked at the doublet, which is another key endpoint, and this is updated data that's now was published last month. When we look at the triplet versus the doublet, really overlapping curves, meaning that the benefit that we're seeing in overall survival now from 5.9 to 9.3 months with the Encorafenib and Cetuximab really is not increased with the addition of MEK inhibition. Now, not unlike what we saw before, however, we did see higher response rates. So, you know, objective response rates were higher in the triplet than in the doublet, and also a sense that there are higher response rates with the triplet when one looked in earlier lines of therapy. So in a third line setting, you can see a 14% response rate with the triplet, 34% response rate in second line. And I don't show slides here, but just acknowledging the anchor study that is going to be presented its final data in ASCO, but preliminary data showed a 50% response rate with the triplet in first line. And we'll follow back up on some of those implications. But with that, you see both a higher response rate from the Beacon study as well as kind of a deeper response. So you get a sense that these waterfall plots are deeper with this. But the difficulty has been the duration of benefit. And so even with the addition of a MEK inhibitor, really no substantial improvement in the progression-free survival, that we're still stuck with between 4 and 5 months progression-free survival on this regimen. And even the anchor study with a 50% response rate really is not showing the type of progression-free survival in first line that would be needed to really explore a targeted therapy alone strategy. So what are the potential implications of this? Really a disconnect between the radiographic responses and the PFS-OS. So this is the concept that increased MAP kinase inhibition may improve the depth of response, but not the duration of the response. And that adaptive resistance is heterogeneous between patient and persists despite dual inhibition. So we're looking at ERK combinations, inhibitors with CDK, and really trying to understand more about mechanisms of signaling at progression. I will mention that efforts are, a study is underway to look at first-line BRAF EGFR with chemotherapy, and so this is the phase 3 study that is ongoing now, and safety lead-in is being conducted currently. So wanted to pivot with that background and really, you know, show how a lot of these same themes are now appearing in other areas and other fields as well. So here, thinking about the role of a G12C inhibitor. So G12C inhibitors are showing a lot of promise in lung cancer, but very similar to what we see in colorectal cancer. The comparison of response rates is fairly modest, and that we don't have, there's not a great single agent signal in colorectal cancer. And so we and others have shown that a very similar mechanisms at play. So this is work by one of my grad students, Olu Coker. And what you can see is that at 24 hours, the use of sotorasib, the Amgen G12C inhibitor, has fairly modest inhibition of phospho-ERK, as shown in the second column. But again, very similarly, when you block KRAS and EGFR, you now get a profound inhibition of phospho-ERK, right? And this is, of course, in a setting where EGFR inhibition alone in a RAS mutant tumor we know has zero activity. And so this is certainly an area of interest for development. When we then look at mouse studies here, this is now looking at G12C inhibitors with EGFR back to our patient-derived xenografts. And what you can see is that about 2 out of 6 models have response with single agent. So there is some activity, but when you add an EGFR inhibitor, you now get a higher rate of 4 out of 6. And a triplet, again, this idea, can you double down on the MAP kinase pathway? Indeed, even in the preclinical models, you can get regressions in almost all the models here. So these themes are really replicating themselves in these settings. And very similarly, when you now treat these models to progression and ask what's happening at 8 weeks, what you can see in these plots, of course, is with the G12C alone, your PERK signaling, MAP kinase signaling is completely restored. And unfortunately, even the doublet of BRAF and EGFR, by 8 weeks, you see restoration of the ERK signaling. So this is really acknowledging the fact that when we're working with adaptive resistance, that sometimes it's not just one feedback node that we need to address, that these are very robust networks where other feedback mechanisms can be at play. And so this is what we can see when we treat the tumors to resistance. And you can see here, for example, a uniform mechanism of resistance out at about 6 months, and others where you get kind of a clonal outgrowth, that some continue to be controlled, but others develop outgrowth in a kind of a clonal manner. So this kind of general theme, I think, following on that, we certainly are seeing the activity of G12C inhibitors in colorectal cancer, and there's a study with Crystal 10, the Mirati study, adagrasib combined with Cetuximab compared with the standard of care. So this is a phase 3 study in second line that is now opening and is an international study with a registration intent. So certainly a number of key questions that remain that are outlined below, and I think this will be a really exciting area as we understand how these tumors are adapting and how we can identify optimal combinations moving forward. So my third and final vignette is really kind of sharing some of the data looking at MEK and CDK4/6 combinations in colorectal cancer. And oh, I'm sorry, I have some duplicated slides here. And so this is based on a screen that was initially done, and Jason Fleming, my colleagues at MD Anderson, who's now at Moffitt, as well as a number of his colleagues, Michael Kim as well, did an ex vivo screen where what we do is make cores of the PDX models, do slices, and actually treat slices of the tumors ex vivo, and looking at a number of various combinations. And this provides a fairly high throughput, or at least moderate throughput screen to look for combinations of interest. And what we did was really focus on combinations of interest with a MEK inhibitor, with the idea that we need to really develop clinical trial mechanisms in patient-derived xenografts. So instead of reporting out, the 2 or 3 PDX models that are working, what we really need to do is to have a rigorous co-clinical trial in the PDXs where we're running a number of preset models through and reporting out the activity across the board, right? Whether it worked or didn't, whatever that activity is, to be able to share that. So this approach is shown here, and what you can see in these models is we are borrowing classic clinical trial design, the Simon 2-stage, right, where we treat some models. If we don't see any activity, we're done. If we see something, then we expand out. And so this is looking for 30% rate of regression. So not just disease, slowing disease growth or even stabilization, but really looking for combinations that give disease regression. And what you can see is that per model that there are varying different effects with the models. And then at the bottom, you see PERK combo. And these are the combinations in the initial screen looking at MEK, then TKI with VEGF predominance. There's a CDK4/6, a MEK-ERK, and penobinostat, HDAC PARP inhibitor, and CDK-ERK combinations. And what was seen is that in this setting, we had four different combinations that triggered the second stage and went on to enroll fully. The end results were really demonstrating that there was one combination that really came out of that ex vivo screen and then the co-clinical trial for further evaluation. And that was the combination of MEK and a CDK4/6 regimen. Now, in parallel, we've been asking questions about the response of these PDX models to MEK inhibitor. And so here we did really took these models, asked how well they responded to MEK inhibition. Remember that very few of these actually formally regressed. It was really about how much were we slowing down growth when we talk about single agent MEK. And one of the key things that came out of this at an RNA level was cell cycle. And then when we did the same thing and looked at it in a proteomic screen, our reverse phase protein array, what we saw was there were a number of cell cycle markers. So PLK1, FOXM1, for example, that came out. And so this really aligned with the fact that we'd previously published that CDK4/6 and MEK inhibition really converge to maximally inhibit this cell cycling signaling here, and that the PLK and FOXM1 really are, critical downstream readouts of the CDK, phospho-RB, and MAP kinase signaling. So when we go back to our mice then and actually ask the question across all of our models, what do we see? And here's all of the data. So a lot of work, and a credit to Alex Sorkin, who led the in vivo team in my group to generate this. What you can see in the red line is that in almost all models, you're seeing at least disease stability, if not regression. And that there's a sense of additivity, if not synergy, between the MEK and the CDK. And so really representing fairly active combinations in vivo. Now, we also know that the hurdle to clinical translation here is we need a therapeutic window, right? And we know the toxicities of MEK inhibitors, of CDK4/6 together. And it took many years, and I wanted to give full credit to Jeff Shapiro, who's been a wonderful partner at the Dana-Farber, who was looking at the combination of binimetinib and palbociclib in lung cancer patients, as well as Mike Lee at UNC, who's now back at MD Anderson, who has been evaluating this in the clinic for colorectal. And indeed, in early days, it's certainly it's a regimen that we're seeing activity. This is one of our first patients on the safety lead-in study, where we can see a G12D mutated patient that has evidence of tumor regression, and you can see the stability of this as well on the right in the CEA. But the question really remains: what's the durability of the response going to be in patients? And so this is a study, a phase 2 study of a MEK CDK4/6, the binimetinib palbo, and you can see the doses that we were able to achieve in our safety lead-in. And this is a study that is mostly enrolled. We just have a few more patients to finish enrolling, and we look forward to seeing the results of this study. This is in a refractory setting, again randomizing versus TAS 102. But we also acknowledge that learning from our experience before, that response may not predict PFS and OS. So what are the factors that predict the durability and the mechanism of resistance really was one of the key questions. And we wanted to try to explore this even before we get our clinical data. And so here, one of the data is showing that the combination in mouse models, and we reduced the doses of these models a little bit so that we wouldn't have to do 9 months of treatments for these mice, until we get resistance. But with these doses, what we could start to ask is, what are the factors not necessarily associated with regressions, but duration of therapy? And here I think you can see that that in the bottom, at least, when you look at the now kind of classic kind of Kaplan-Meier look to the data in terms of durability, there's really no difference whether it's a codon 12 or 13 or more extended RAS sites. But there is a kind of an interesting difference by CMS, where we see patients with CMS2, but or I should say mouse models of CMS2, but less so CMS3 deriving this benefit. So this actually provides a pre-specified hypothesis about what potential biomarkers we could be exploring moving forward. But the other thing it allows us to do is now ask the question, all right, we've blocked 2 critical nodes in MAP kinase signaling. How is the tumor adapting, right? Back to our concepts of adaptive resistance. And we look at this now at the point of progression. We don't really see much difference in mTOR signaling, for example, or alternate like P38 signaling. But what we do see here is RTK signaling coming up, and one of the key ones is SHP2. Now, SHP2 is a phosphatase that is between the receptor tyrosine kinases and the RAS signaling pathway. And what you can see now across all the models is that phospho-SHP2 levels go up in the combination of the Trametinib and the palbociclib. And that the data then suggests that when you look at the combination and look at models that are now progressing, when you then add on a SHP2 inhibitor, you can now induce regressions again in these models. So this is at least giving us a hint of additional strategies that we could explore, and really this idea of adaptive feedback mechanisms is very relevant, and I think trying to understand how we best tackle some of these approaches and keeping an eye on these adaptive feedback mechanisms as we move things into the clinic is critical. So just to conclude, just to acknowledge that that adaptive resistance is common in targeted therapies in colorectal cancer. This is a tumor type that is very sensitive to these feedback mechanisms, and it's a tumor that that time and again has shown that that single node inhibition is of less benefit. The second point is just acknowledging that the work in BRAF, that that while BRAF and EGFR now has FDA approval, I think we all acknowledge we need to do better, continue to work on understanding how we can intercept this in a better way. And I think there are studies now ongoing looking at combinations with CDK4/6, with ERK inhibitors, with pan-RAF inhibitors, but also with SHP2 inhibitors, and they will explore some of these therapies I think will be important. And I would argue that I'm encouraged by the MEK-CDK4/6 combination. I think we really have to see, how the therapeutic window plays out across a larger number of patients, and recognizing the magnitude and the duration of benefit really remain to be seen in the randomized phase 2. So rational doublets and triplets may be active in many settings, and I think really following the principles of combinatorial adaptive resistance therapy, hopefully we'll be able to really develop improved therapies in the future. So I'll end, acknowledge, I think certainly, hopefully acknowledged as we went along, but you know, Alex Sorkin, who leads our in vivo in vivo team here in the lab, Olu Coker, who was working on the G12C story, Mike Lee, fellow and now colleague in GI Medical Oncology, who has been helping to spearhead the MEK-CDK combination, Joseph Tabanero for collaboration of the BRAF EGFR along with Ryan Corcoran, and then Jeff Shapiro for his great collaboration with the MEK-CDK. So with that, I'll end, and thank you for your time, and happy to take any questions.
Thank you, Scott, for this really outstanding talk. If you have any questions, please use the Q&A feature located at the bottom of your screen. While we wait on questions, I wanted to let you know that the next week's Grand Rounds will feature Dr. Faye Johnson from the University of Texas MD Anderson Cancer Center, who will be presenting head and neck cancers poised for a precision medicine revolution. To view all upcoming Winship Grand Rounds lecture, please visit Grand Rounds page on Winship Cancer Center website or the Winship calendar. So let me look into the Q&A. It seems that we have some questions. First one from Dr. Waller. Great talk. Do normal tissues and cells have similar ability to homeostatically adjust the activities of intracellular signaling pathways during combination therapies?
No, it's a great point, and yes, so we actually do see that many of these networks are present in normal epithelial cells, but to a lesser degree. So we do see some of these. I think part of it is that the tumor cells are at a very high rheostat, right? The very high level of signaling, and so when their homeostatic settings are at a very high level of MAP kinase signaling, it's a very clear-cut mechanisms and feedback and adaptation. But these signaling appear to be present in some of the normal epithelium as well, albeit to just a lower degree.
A similar but different question from Greg Lazinski. Do you think these mutations, the resistant mutations that is, are always present in the tumor as heterogeneous clones, or do you think they arise during the course of targeted chemotherapy as a way to thrive? Are we selecting those clones with therapy, or were they there from the beginning?
Yeah, great question. And I think the answer is yes. Maybe it's probably both. But so there are certainly, if we go back to where we have the most, most data on, EGFR, for example, and we're seeing the acquisition of RAS mutations, we can indeed go back and find these rare clones. And likewise in BRAF, we can find an occasional, very rare low levels of RAS clones that are present. However, there are alterations that occur at resistance that we never see, and that's a bold statement, but we really, looked hard, but we really never see them de novo, right? So ectodomain mutations around EGFR, for example, which is mechanism resistance for cetuximab. So there's a sense that it may be a bit of both, that there's a proportion of patients that have some pre-existing clones that are poised to it, but then there are others that it's actually, there's a loss and inefficiency in some of the mismatch and DNA repair mechanisms that can be induced by some of this targeted therapy. So beautiful paper by Alberto Bardelli in Science, I think end of middle of last year maybe, that really kind of showed nicely that that when you inhibit some of these signaling pathways, you can induce a state of lower DNA damage repair and can transiently at least set these tumors up to be more prone to develop these resistance mutations, which then obviously with the setting of selective pressure can outgrow. So there's been a lot of interest about how do you could you profile patients to really understand who has a microscopic RAS clone ahead of time, and maybe those are ones that are going to be more likely to outgrow. But actually, there's some data that we'll be presenting at ASCO for EGFR inhibitors that I think is a bit provocative, that actually says, we can find rare clones in patients prior to EGFR inhibitors, but it actually turns out that those rare clones aren't always the same ones that grow out, right? So even when they're present ahead of time, that doesn't actually mean that those are going to be the resistance mechanisms that will take off. And it's actually a fair bit of a disconnect there, which I think is just absolutely fascinating. So there's a lot we still don't know.
So next question is from Dr. Aleshi. Can you comment on differences in therapeutic strategy between patients with de novo and therapy-induced RAS mutated colorectal cancer?
Yeah, so therapy-induced, whether it's kind of BRAF or EGFR, combinations in the right settings where we see these mutations acquire. I think the key difference is that obviously the de novo tend to be clonal events. One of the things that is also fascinating in this is that when you see a patient progressing on Cetuximab and they have acquired a KRAS clone, it's not that that KRAS clone has populated the entire tumor, and that instead what we see is that it's really a minority of the cells that have that KRAS mutation, and that there's a proportion of other mechanisms, but also some PERK effects induced by the KRAS mutation, we think, that may be kind of driving the fact that the totality of the tumor is progressing. But that subclonality we can take advantage of because we kind of think simplistically about MAP kinase signaling as a good thing for a cancer cell, but it really is a bit of a Goldilocks phenomenon. And when cells are overdriven on the MAP kinase pathway signaling, they can induce senescence. And one of the things that we see is that when you have a tumor that has been treated with an EGFR inhibitor, in order to adapt, a clone develops a RAS mutation, and the cell is returned to some perfect Goldilocks state of MAP kinase signaling. As soon as you withdraw that EGFR inhibitor, now that cell has really high levels, too high levels of MAP kinase signaling, and you can actually drive some of those cells over the edge, and they can actually then induce senescence in some settings. And so we see this in the clinic because once we remove an EGFR inhibitor, we'll see that RAS clone start to decay. We actually modeled this in patients and said it decays with a half-life of about 3 to 4 months. So over time, those RAS clones, when they're therapy-induced, will start to degrade. And so that's kind of a really fascinating area, and I think a lot of interest in trying to understand, well, how do you use that therapeutically, right? Can you drive these cells to senescence? Can you just wait long enough and maybe these clones regress and you can re-challenge, as we're now starting to do in the clinic with EGFR inhibitors. So I think the therapeutic strategies with this therapy-induced RAS mutation, a lot of it's trying to take advantage of that Goldilocks phenomenon, which obviously is not the case with the de novo mutated ones. Good question.
So one question from Dr. Shin. BRAF EGFR target appears to be an excellent strategy. Any role for this regimen in the neoadjuvant or adjuvant setting in colorectal cancer?
Yeah, it's likewise a great question, and it's an area that's being looked at. So neoadjuvant, the neoadjuvant strategy, there's some discussion about potential there in rectal, but I don't think I think it's just kind of too small of a population. Remember, BRAFs are typically right-sided, so the rate of V600Es in the rectal cancers are pretty low. And the neoadjuvant for liver met that I mentioned, these are tumors that tend to go to the peritoneum, to other distant lymph nodes, much more likely. So there's a very low number, not zero. We do have some patients that can go for a hepatectomy and can even potentially have really wonderful long-term outcomes, but that's the minority. But I think that adjuvant is where we really are going to see, see some activity there. And so Rona Yeager is developing a trial, a very large adjuvant study to look at this combination of BRAF and EGFR with chemotherapy potentially in the kind of adjuvant setting for stage 3 colorectal cancer. So or at least colon cancer, I should say. So that's a study that's still kind of in the discussion, in the works. I don't know that there's any decision on whether that will actually see the light of day yet or not, but I do think that's an opportunity to improve upon things.
Excellent. Again, Scott, thank you for this really excellent grand rounds, and thank you for presenting today. I think we have no more questions. Again, looking forward to hearing from you soon. Thanks.
Oh, thank you for the invitation and time. Thank you all.
Bye.